طيب بسم الله الرحمن الرحيم. In this lecture we are going to continue the anatomy of the pelvis and perineum, and we started our first lecture last time with talking about the pelvic walls, and this lecture is going to be about pelvic cavity viscera or organs. In order to understand the anatomy of the pelvic viscera, you need to know the pelvic walls, which we have covered in the last lecture. Anatomy is all based on each other, and medicine, in fact, all medicine is all based on each other. So basic science will make you prepared for the clinical science and so forth. So in the 5 minutes of this lecture, while we get the other students joining this, the lecture, I'm just going to go through a very quick revision of our previous lecture about pelvic walls, because this is important for today's lecture. So we said there are three main components of the anatomy of the pelvis and the perineum: pelvic walls, which was the last lecture, pelvic cavity this lecture, and perineum will be our next lecture. So the pelvic walls, as we said, there is anterior, posterior, lateral, and inferior pelvic walls, and we spoke about the different walls as follows. So we started by introduction about the pelvic bones, and we said there are two hip bones, sacrum and coccyx, and we said there are two parts of the pelvic cavity, true and false, and they are divided by what we call the pelvic inlet, which is pelvic brim. And then we started speaking about the orientation of the pelvic bone, and we said the symphysis pubis should be in line with the anterior superior iliac spine. We said there are three main components of the anterior pelvic wall: the pubic bones, the rami, the symphysis, and in the posterior, we said there is the sacrum, the coccyx, piriformis, muscle, and fascia, and in the lateral wall, we said there are the hips, obturator membrane, and obturator muscle, internus, and sacral ligaments, sacrotuberous and sacrospinous ligaments. And we said the inferior wall or the pelvic diaphragm is formed mainly by the levator ani muscles and the coccygeus. Then we spoke about the different components of the posterior wall, including the sacrum, the coccyx, and the piriformis muscle. We also covered the vertebrae, the lateral wall, and then we spoke about the hip bones and how it develops and how it's three bones in the children, including the ilium, ischium, and pubis. They become like one bone in the adult. We have also covered the obturator membrane and obturator foramen, obturator canal, and obturator nerve and obturator vessels. So if you remember, we have spoken about the obturator internus muscle and the sacral ligaments, sacrotuberous, sacrospinous, and sacroiliac ligaments. Then we spoke about the inferior wall or the pelvic diaphragm, the levator ani muscles, and the two parts of the levator ani muscles and the coccygeus muscle posteriorly and the functions. And about each muscle, we should, as we said last time, know the origin, insertion, nerve supply, blood supply, including arterial and venous, arterial supply and venous drainage and lymphatic drainage, as well as the action of the muscle. Then we moved to nerves. We spoke about the sacral plexus, the lumbar plexus, the autonomic nerves, sympathetic trunk, and the parasympathetic autonomic nerves. Then we moved to pelvic vessels. We have spoken about the common iliacs dividing into internal and external iliac vessels. And then we spoke about the internal. We said the internal iliac vessel supplies the pelvic cavity, and the external iliac vessel goes to the lower limb, if you remember all of that. And then we spoke about the branches of the internal iliac artery. If you remember ILS and UBO and BRG, we had a chat about the different branches. All this, the lecture and this lecture and all lectures are available online on the YouTube channel, so you can revise the different branches of the internal iliac artery, and we gave them names LCUVO, BRG, and SOM or ROS, if you remember. We said the veins follow the arteries. They have the same names as the arteries. And then we spoke about the pelvic joints, the sacroiliac joints, and the hip joint we'll study in the lower limb, and then the symphysis pubis. Then we spoke about the main differences in the pelvis between the two sexes, males and females, and we said it's mainly because it makes the pelvic bone in females ready for childbearing and delivery, and we said the muscle markings are prominent in males because of the muscle attachment, and then we said there are differences in the false pelvis, in the inlet, in the cavity, in the outlet, in the sacrum, and in the pubic angle, and you know all these differences, I'm sure. And that was it. So this was the previous lecture. Any question about the pelvic walls? Do you remember the lecture of the pelvic walls? Those who don't remember or who hasn't attended the pelvic wall lecture should go back to the YouTube channel and watch that lecture. But a lot of the information we'll mention today will be based on the information we got from the first lecture about the pelvic cavity. So today we'll cover the pelvic cavity based on the information we just heard about the pelvic walls. Now we are going inside the cavity. There is a quiz I have put on the group, and the quiz was mainly to answer before, but for those who didn't get a chance to go through the quiz, we will cover the quiz at the end of this lecture. It's going to be 1 hour or less lecture, and we'll cover the quiz. If we speak about the body trunk cavities, how many cavities when we say the body trunk, if you exclude the head and neck and upper limbs and lower limbs, whatever is left, the middle part of the body is called the trunk. And the trunk is composed of 3 cavities. These 3 cavities include the chest, the abdomen, and pelvis. So the chest and abdomen are separated by what we call the diaphragm, and the abdomen and pelvis are separated by the pelvic inlet. And we have set the boundaries of the pelvic inlet in our previous lecture. So when we say pelvis and abdomen are separated by the pelvic inlet, we mean the main pelvic cavity, because the false part of the pelvis is above the inlet. So the inlet separates the false pelvis, because the false pelvis is actually part of the abdominal cavity. So when we say the main pelvic cavity, we mean the true pelvis or the true pelvic cavity. And the diaphragm and the pelvic diaphragm are actual muscular diaphragms, but the pelvic inlet is an imaginary plane formed by different borders. I'm not going to mention them again. We said them in the last lecture. This separates the abdomen from the pelvis, and the pelvis is separated from the perineum by the pelvic floor. So we have diaphragm, inlet, and pelvic floor. The diaphragm separates the chest from the abdomen. The pelvic inlet separates the abdomen from the pelvis, and the pelvic diaphragm separates the main pelvic cavity from the perineum. So content of the pelvis, because of the reproductive organs, the pelvis content is different from males and females. However, if we divide the pelvis into systems, there are 3 main systems: the digestive system, the lower part of the GI system, including bowel; the urinary tract, the lower part of the urinary tract, including the ureters and the urinary bladder; and then the reproductive system. And of course, the reproductive system is different between males and females. So in males we find the vast difference: the seminal vesicles, ejaculatory ducts, prostate, and prostatic urethra. In females we find the ovary, the uterus, and vagina. The digestive system, the terminal part of the digestive system which is present in the pelvis, includes the lower coils of the ileum. That's why we study the ileum with the abdomen as part of the small intestine, but only coils of the lower coils of the ileum, they dip into the pelvis, so you can find some coils of the ileum into the pelvis. However, you find the whole sigmoid colon and rectum in the pelvis. So today we're going to talk about the sigmoid colon and rectum, and we'll leave the ileum to study with the rest of the main part of the ileum when we cover the anatomy of the abdomen. The urinary tract, again, it starts from the kidneys, ureters, but the kidneys and the abdominal part of the ureters we will study with the abdomen. We will only study the lower part of the ureters, which are in the pelvis, together with the urinary bladder in this lecture. So if we divide the pelvic cavity in two parts, anterior and posterior, the anterior is similar in both sexes. The posterior is similar in both sexes. So if you can follow my cursor, this is female pelvis and this is male pelvis. So if you cut into half, the posterior part of the pelvis is similar between males and females, and it's mainly filled by the bowel, which is the terminal coils of the ileum, the sigmoid colon, and the rectum. They are similar in both sexes. So when we cover the anatomy of the posterior part, we will speak like one sex. So there are no major differences between the posterior part of the pelvis between males and females, because it has got the bowel content which are the same. The urinary tract and the reproductive system, which is the genital organs, are found in the posterior part of the pelvic cavity. Therefore, there are major differences between the anterior part of the pelvic cavity is different between males and females because of the presence of the reproductive system. Of course, the reproductive system is totally different, but because the urinary system is close to the reproductive system, there are also differences in the urinary system. So it's mostly similar when we speak about the structure of the bladder and the physiology and contraction. And relations. There are many similarities between the urinary systems, but because of its close proximity to the genital organs, there are also a lot of differences between the urinary systems in the male and female. So in this lecture, we will cover two of the three systems. We will cover the bowel, the digestive system, which is similar between males and females, including ileum, sigmoid colon, and rectum. And we will also cover the urinary system. And the urinary system, as we said, is similar, but because of proximity to the genital organs, anatomy is also different between males and females. And in the next lecture, we are going to cover the genital organs, the reproductive system, both in males and females. So if we start with the digestive system, as we said, we'll cover the ileum with the abdomen because it's part of the abdomen. Only small coils of the lower ileum drop into the pelvis. So we'll cover the whole thing when we speak about the small intestine in the abdomen. So the sigmoid colon is whole. All of the sigmoid colon is in the pelvis. The sigmoid colon is 10 to 15 inches long, and it's easy to measure in inches because you can easily understand or remember 10 to 15. But if you know, some people they use centimeters, the metric system, to convert inches to centimeters. You should know that every inch is 2.5 centimeters. Every inch is 2.5 centimeters. So 10 times 2.5 is 25, and 15 times 2.5 is 37.5 or 38. Anyway, the sigmoid colon is 10 to 15. The rectum is 5. The rectum is 5 inches, which is 13 centimeters. The sigmoid colon is 10 to 15. So it's easy to remember 5, 10, 15. So rectum is 5, sigmoid colon is 10 to 15 inches. If you want to convert the inches into centimeters, you multiply it by 2.5, which means the rectum is 13, which is 12.5 centimeters, and the sigmoid colon is 25 to 37.5 or 38 centimeters. So the descending colon is in the abdomen. As you know, the large intestine or the colon has got an ascending part, transverse part, and descending part. We will study that in the abdomen. The continuation of the descending colon when it leaves the abdomen to enter the pelvis is called the sigmoid colon, and the continuation of the sigmoid colon is called the rectum, and the continuation of the rectum is called the anal canal. So the large intestine has got the following parts. It's all one tube, but it has got different names according to the region. So it starts as ascending, which goes upwards in the abdomen, transverse, which goes transversely from the left, from the right to the left, and then descending, which goes down. And the descending, when it enters the abdomen, the name changes to sigmoid colon, and then the sigmoid colon changes to rectum, and the rectum continues as the anal canal. So the point where the descending colon changes its name to the sigmoid is the pelvic brim, because that's the, as we said in the first lecture, in the first slide, the abdomen is separated from the pelvis by the pelvic brim, and the pelvic brim is the same name for the pelvic inlet. This is the imaginary plane which separates the abdomen from the pelvis. So once the descending colon crosses the pelvic brim or the pelvic inlet, that means it's crossing from the abdomen to the pelvis. Therefore, the name will change from descending colon to sigmoid colon. And it continues until the front of the third sacral vertebra. I will show you the picture in the next slide. We have a slide with a picture. I'll show it to you. These landmarks are important because they ask you in the exams, where is the sigmoid colon starting at the pelvic inlet or pelvic brim, and where is it ending? It's ending in front of the third. S3 is the third sacral vertebra. So in front of the third sacral vertebra, the sigmoid colon will become the rectum. It's a mobile, and it hangs down as a loop, and this loop is attached to the posterior pelvic wall by something called sigmoid mesocolon. Mesocolon is the mesentery of the colon, and the sigmoid mesocolon is fan-shaped. It's fan-shaped to make it mobile. So it's mobile. It's hanging in the pelvic cavity as a loop, and it's attached to the pelvic wall, to the posterior pelvic wall, by the sigmoid mesocolon, and the sigmoid mesocolon is fan-shaped. It looks like a fan. This is up to the end of the sigmoid colon in front of the third sacral vertebra. The relations, we always in anatomy try to imagine the relations. If you imagine the relations, it's better than keeping them, because if you keep them, you will forget them. But if you look at the picture, I'll show you one picture now. The sigmoid colon has got in front of it the bladder in the male, but as we said, in the female, the genital system goes between. If you see here, this is the sigmoid colon. In the male, you have the bladder straight away, but in the female, the genital system goes between the digestive and the urinary system. Therefore, instead of having the bladder like in the male, the uterus and the upper part of the vagina intervene between the sigmoid colon and the bladder. In the male, there is nothing here between the sigmoid colon and the bladder. So go again. So in the male there is the bladder. In the female, between the sigmoid colon and the bladder, you'll find the posterior part of the uterus and upper vagina. However, posteriorly you'll find the rectum and sacrum in both males and females. So behind, because it's posterior part of the pelvic cavity, is similar. You'll find the rectum and sacrum. This is the sigmoid colon. Sacrum and rectum. Male, sacrum and rectum in the female, posteriorly. But anteriorly, in the male, you'll find straight away the bladder. In the female, between the bladder and the sigmoid colon and the rectum, you'll find the uterus and the vagina. So the frontal or the anterior border of the sigmoid colon in the female is not the urinary bladder, is the uterus and the upper part of the vagina. Is that clear so far? Any question? Do you understand? I want somebody to tell me about the anterior relations of the sigmoid colon. A volunteer. In the male and in the female, what do we find anterior to the sigmoid colon? Jinwan?
Anteriorly in the male, we have the bladder.
Yes.
And in the female, we have the uterus and vagina.
The upper part of the vagina. Posterior relations are the same, sacrum and rectum. Blood supply, the sigmoid colon is supplied by the sigmoid branches of the inferior mesenteric artery, and the veins go back to the inferior mesenteric vein. The inferior mesenteric vein drains into the portal system, which we will study in the abdomen. The lymphatic drainage always follow the arterial supply, so it follows the sigmoid arteries to the inferior mesenteric lymph nodes. So if you see here, the arteries, veins, and lymphatics, they go together. So from the sigmoid colon, there are sigmoid branches, arteries, and sigmoid branches, veins. The sigmoid branches, arteries, come from the inferior mesenteric artery. The sigmoid branch veins drain into the portal system, and the sigmoid lymphatics follow the sigmoid artery. Therefore, because the sigmoid artery goes to the inferior mesenteric vein, the sigmoid lymphatics go to the inferior mesenteric lymph nodes. While the sympathetic, these are all visceral, they don't have somatic, like you don't have sensation like feeling and muscle like somatic muscles, but these are just smooth muscles, so they have autonomic sympathetic and parasympathetic, and they both come from the inferior hypogastric plexus. Now we move to the rectum. As we said in the colon, in the sigmoid colon, that the rectum starts at the end of the sigmoid colon, so it starts in front of S3, which is the third sacral vertebra, and as I said, it's 5 inches long. The sigmoid colon is 10 to 15 inches long. The rectum is shorter, it's 5 inches long, and it starts where the sigmoid colon ends, which is in front of S3. It goes downwards following the sacrum and coccyx curve. So the rectum goes like this, downwards. The sigmoid colon is coming from the left, from the descending colon, hanging down like a loop, and then going back to the S in front of S3, which is the third sacral vertebra. However, the rectum is shorter, 5 inches in front of like 10 to 15 inches, and it goes down as a straight line following the curvature of the sacrum and coccyx. So the rectum ends where it continues as anal canal. So we said the pelvic diaphragm is a separation between the main or true pelvic cavity and perineum. So when the rectum pierces the pelvic diaphragm, it becomes the anal canal. So this is the pelvic diaphragm. The rectum changes its name. It is the same tube changes its name. So the rectum starts where the sigmoid colon ends at S in front of the third sacral vertebra and ends where it pierces the pelvic diaphragm, because this is the end of the pelvis and the start of the perineum. So we will study the anal canal when we study the perineum, but for now the rectum ends by piercing the pelvic diaphragm to become the anal canal. The rectal ampulla is a dilated part of the lower part of the rectum. So the lower rectum is called the rectal ampulla. This part here, the part just above the pelvic diaphragm, is called the rectal ampulla. This is one of the questions in the quiz. What is the rectal ampulla, or the ampulla of the rectum? Is the lower, dilated lower part of the rectum just before it pierces the pelvic diaphragm to become the anal canal. This is called the ampulla of the rectum. In rectal angle, this is very important. It was also one of the questions in the quiz. Is a sling formed by puborectalis. Puborectalis, if you remember from the pelvic wall's anatomy, that puborectalis is one of the portions of the levator ani muscle, and it forms a sling around the rectum at the junction with the anal canal, and this helps as the sphincter for the rectum. So it forms a sling. The sling will go around the lower part of the rectum before it changes its name to the anal canal here, and it helps as the anal sphincter or rectal sphincter. So we know anorectal angle is formed by a sling of puborectalis. Rectal ampulla is a dilated lower part of the rectum. Peritoneal cover is very important. The rectum is divided into 3 thirds. The upper third of the rectum is covered by peritoneum anteriorly and laterally. The middle third is only covered by peritoneum anteriorly. The lower third is devoid of peritoneum. Peritoneum ends here, so the lower third has no peritoneum. The middle third has only the peritoneum covering it anteriorly. The upper third is covered by the peritoneum anteriorly and laterally. I want somebody to tell me about how the peritoneum covers the rectum. The upper third is covered anteriorly and laterally. The middle third is only covered anteriorly. The lower third is devoid of peritoneum. Can anybody answer? Can anybody say that again? Shahad, tell me about peritoneal cover of the rectum. Anybody? Arwa? Rawan? Tijani?
The upper is covered anteriorly and laterally, and
Yes.
the middle is covered anteriorly, and the lower has no covering.
Excellent, Arwa. So this is the cover. Now we move to the muscle. The muscle of the rectum is divided into outer longitudinal and inner circular layers. So the outer layer is longitudinal, going along the line of the rectum, and the inner layer is circular, going round like that. Now the inner circular layer with the mucous membrane, these together, they form 3 permanent folds. The rectum, when you draw the rectum, you don't draw it as a straight line. There are 3 permanent folds. They even have names. The upper left, the right, in the middle, and the lower left. So 2 on the left and 1 on the right. 3 permanent folds. These are called semicircular folds. These are permanent folds. These are formed by the inner circular layer of the muscle of the wall of the rectum together with the mucous membrane of the rectum. So the semicircular permanent transverse folds of the rectum, two on the left, one on the right, and the two left are called upper and lower, are formed by the mucous membrane together with the inner circular layer of muscle. So we know about the cover by peritoneum, we know about the muscle, smooth muscle of the rectum is divided into outer longitudinal and inner circular, and we know that the mucous membrane together with the inner circular layer forms the permanent folds of the rectum, and we know that there are two folds on the left called the upper left and the lower left, and there is one in the right called the right in the middle, or called the middle transverse, right middle transverse fold of the rectum. So this is how you see it from inside. If you do sigmoidoscopy or colonoscopy, you see the folds like that. This is the right and this is the left. Relations, again, it depends on whether it's a male or female. In the male, anteriorly you find the sigmoid colon and ileum and the bladder. However, in the females, you will find the recto-uterine pouch, and this is called the pouch of Douglas. So this was one of the questions in the quiz. What is the pouch of Douglas? You don't find pouch of Douglas in males. In males it's called the retrovesical pouch, but in the females, because behind, retrovesical means behind the bladder. Behind the bladder in the female there is the uterus, so it's called the recto-uterine. So it is retrovesical pouch in the male, recto-uterine pouch in the female, and the vagina. So we go again. Posteriorly it's easy. Posteriorly, sacrum, coccyx, piriformis. This is the posterior pelvic wall. So if we go back here, posterior to the rectum, we find the same structures of the posterior pelvic wall. And if you remember, we said posterior pelvic wall has got bones, muscles, and nerves. The bones are the sacrum and coccyx. The muscles are the piriformis and coccygeus, and the nerves are the sympathetic plexus and the parasympathetic nerves. So behind the rectum in males and females, it is the posterior. If you say the posterior pelvic wall, that's fine, but you should know what's in the posterior pelvic wall. It's bones, muscles, and nerves. However, anteriorly it's different between males and females. In the males, anteriorly you will find the bladder and the sigmoid colon. As we said, posterior to the sigmoid colon is the rectum, then anterior to the rectum is the sigmoid colon. So in the male, anterior to the rectum, you find the sigmoid colon and the bladder. The space between the bladder and the rectum is called the rectovesical pouch in the male. Rectovesical pouch. In the female, if there is no uterus, it's exactly the same, but the uterus comes in the middle. When the uterus comes in the middle, it separates the rectum from the bladder. Therefore, instead of rectovesical pouch in the male, we have recto-uterine pouch, and the name of the recto-uterine pouch, which is exactly in the same place as the rectovesical pouch in the male, is pouch of Douglas. So what is pouch of Douglas? In the MCQs we said it is recto-uterine pouch or rectovesical pouch. Tara, if you are there, what is the pouch of Douglas? Is it the rectovesical pouch or the recto-uterine pouch? Anybody? Is the pouch of Douglas recto-uterine or rectovesical? I think I can't hear you properly, but it's the you're right, rectovesical pouch, rectouterine pouch. So the rectovesical pouch in the male is between the rectum and the bladder. In the female, the area between the rectum and the bladder is filled by the uterus. Therefore, the name of the pouch, of the same pouch in front of the rectum, is not the vesicle, it is the rectouterine pouch. Posteriorly, it's the same to the rectum. Now we move to the blood supply of the rectum. The rectum has got superior, middle, and inferior rectal arteries. Superior, middle, and inferior rectal arteries. I'm not going to repeat that again, but we spoke about that when we spoke about the about the pelvic walls, that they come from different origins. The superior rectal artery is actually the direct continuation of the inferior mesenteric artery. Superior rectal artery is the direct continuation of the inferior mesenteric artery. So the superior rectal artery is not coming from the internal iliac artery. Do you remember I said there are three arteries not coming directly from the internal? They are entering the pelvis from different origins. One of them is the superior rectal artery. Superior rectal artery is the direct continuation of the inferior mesenteric artery. The middle rectal artery is a branch of the internal iliac artery, and the inferior rectal artery is a branch of the internal pudendal, which is a branch of the internal iliac artery. So the superior rectal artery supplies the mucous membrane, the middle rectal artery supplies the muscle, and the inferior rectal artery anastomosis with the middle rectal artery at the anorectal junction. The veins correspond to the arteries, so there are three veins: superior rectal vein, middle rectal vein, and inferior rectal vein. There is a very significant clinical importance to the rectal venous drainage, because it forms one of the significant 5 or 6 important portosystemic anastomosis in the body. I'm not going to talk about that now, but this is a very important clinical significance, like the esophageal varices, where the portal vein meets the systemic veins, is called portosystemic anastomosis, and one of them is formed here, because if you see here, we said the junction of the tributaries of the middle and inferior and superior veins, they form an anastomosis, and part of this will go to the portal circulation through the superior, and part will go to the systemic circulation. So the rectal veins form one of the important portosystemic anastomosis areas in the body. So when we talk about the portal system and portal hypertension, we will mention that. The lymphatic drainage always follows the arteries and veins, as we said. It goes like the sigmoid colon up to the inferior mesenteric nodes, because the superior rectal artery is direct continuation of the inferior mesenteric artery. So the lymph nodes will go in the different direction through the superior rectal artery back to the inferior mesenteric nodes by the inferior mesenteric artery. The nerve supply is again like the sigmoid colon, autonomic and sympathetic and parasympathetic from the inferior hypogastric plexus. There is one last information which is very important. The rectum is sensitive only to stretch. So the autonomic nervous supply to the rectum is to detect stretch in the rectum in case of constipation. So this is the arterial blood supply, which we said that the superior rectal artery is a direct continuation of the inferior mesenteric artery, and then we have the middle rectal artery and the inferior rectal artery. So we finish with the GIT. We move to the urinary tract, and we said in the pelvis we have parts of the urinary tract, including the pelvic part of the ureter as well as the urinary bladder. So the ureter is a tube starting from the kidney down to the bladder. However, part of it is in the abdomen and part of it is in the pelvis. So when it crosses the bifurcation, the pelvic brim here, this green structure is the ureter. When it crosses the pelvic brim here, it is the same structure, but it changes its name from the abdominal to the ureteric part, to the pelvic part of the ureter. So the ureter enters the pelvis by crossing the bifurcation of the common iliac artery. If you remember, the common iliac artery divides into internal and external iliac arteries. So in front of the sacroiliac joint, this the ureter will cross in front of the sacroiliac joint at the junction of the abdomen with the pelvis. The ureter crosses and enters the pelvis, and this will be where the common carotid artery divides into the internal carotid artery, which goes into the pelvic cavity, and the external carotid artery, which goes down to the lower limb. So it goes laterally. If we follow it in the diagram, it goes down on the lateral wall until it reaches the area of the ischial spine. So this is as if you're cutting the pelvis into two halves. The ureter will enter here. This is the front. This is the back. The ureter will enter in the middle, but it will go laterally towards the area. If you take the muscle out from here, this is the ischial spine. يعني بيمشي laterally لحد ما يصل الاريا بتاعت الاسكال سباين هنا. اول ما يصل الاريا بتاعت الاسكال سباين بيبدا يرجع medially and downward again. It is the same in male and female up to here, but when it comes medially, the relations will be different here, because here it will be crossed by the vas deferens, but here it will be crossed by the uterine artery at the same area. So the course of the ureter is the same until just before it joins the bladder, because there are different structures. It will be crossed by the vas deferens before it joins the bladder, and it will be crossed by the uterine artery before it joins the urinary bladder. It's an oblique pass through the wall. يعني لما اليوريتر يدخل البلادر بيدخل obliquely. والoblique length of the ureter in the bladder is almost 2 centimeters, is 1.9 centimeter, and this is to help as a sphincter action, as a valve action. So this will help as a valve action, because if you see the bladder wall is thick, the ureter will cross it in an oblique line about 1.9 centimeters, and this is actually one of the 3 areas which you will have constrictions in the ureter. The ureter has got constriction when it goes out from the bladder, and that's called the renal pelvis. So the junction of the renal pelvis with the ureter, this is the first constriction. The second constriction is when it enters the pelvis as the pelvic grim, and the third constriction is when it enters the bladder at the bladder wall. I will say that again, and then I will ask somebody to repeat that. This is a very common question. I was putting it as one of the questions, and then I took it out. The ureter has got 3 constrictions. When it comes out from the bladder at the junction of the ureter with the renal pelvis of the bladder, when it enters the pelvis in the middle at the pelvic brim or pelvic inlet, and when it enters the wall of the urinary bladder. Who wants to answer that question? And please raise up your voice. Tijani, what are the 3 constrictions of the ureter? Rawan,
Yes, يا دكتور عمار.
what are the 3 areas of constriction of the ureter? I'll say it again one last time. The upper part is where it joins or where it comes off the kidney, at where it joins the pelvic, the renal pelvis of the kidney. When it becomes the ureter, this is the upper point. The middle point is where the ureter enters the pelvis at the pelvic brim or pelvic inlet, and the last one is where it joins the wall or where it pierces the wall of the bladder. معناها واحدة في الأول، واحدة في النص، واحدة في الآخر، واحدة في الجنكشن مع الكدني في أول اليوريتر، واحدة في النص لما اليوريتر يدخل البلفس في الإنلت، واحدة في الآخر لما اليوريتر يدخل اليورينري bladder. These are the three constrictions of the ureter. Can you say them?
Yes. So the first one is when it joins with the kidney, like in a.
Yes. And the second one? I'm traveling. I have very poor connection. I can't hear Rawan. Can you hear her, guys? Anyway, the three constrictions, as Rawan said, at the renal pelvis, at the pelvic brim, and at the bladder wall. So, because the ureter is mainly in the abdomen, we will cover its blood supply, lymphatic drainage, and nerve supply with when we speak about the anatomy of the abdomen. And we said in the relations, the main difference, the ureter course is the same, but the main difference is when it approaches the urinary bladder, it's crossed by the uterine artery in the female and by the vas deferens in the male. Now we move to the urinary bladder. The urinary bladder is a strong muscular sac immediately behind the pubic bones. So if we see this here, the bladder lies immediately behind the pubic bones in the male and in the female, and it can take up to 500 mils. يعني نص لتر يا شباب. البلادر can take roughly up to 500 mils of urine. The shape and relations will depend on the volume. يعني the empty bladder, it looks and it has got different relations than the full bladder. So the empty bladder in the adult is completely inside the pelvis, يعني behind the pubic bones. This is a sagittal view, يعني you see it from the side. So the bladder is completely in the adult inside the pelvis. When it becomes full, it can go up to the hypogastric. Hypogastric, the upper part of the abdomen, is called, the lower part of the abdomen is called the hypogastric. So you can feel a full bladder of a patient, but you cannot feel an empty bladder. When the bladder is empty, you cannot feel it because it's behind the bone, but when it is full, you can feel it because it goes above the bone into the hypogastrium. The empty bladder is pyramidal in shape, يعني شكلها زي الهرم, while the full bladder becomes ovoid in shape, زي البيضة, oval, ovoid. The empty bladder has got an apex, والapex هو البارت behind the pubic bone. هنا الapex بتاعت البلادر is the part of the bladder of the empty bladder behind the bone, والneck هي البارت just before the urethra. هنا بعد ذاك عندها base وعندها infrolateral surfaces، هنيجي نتكلم عنهم بعد شوية. يبقى عندها apex وبيس وsuperior surface وtwo infrolateral surfaces وneck وposterior surface. أنا كنت بحفظها زمان بقول 3 parts و 3 surfaces. ال 3 parts هم الابيكس والبيس والنك. البيس هي actually الposterior surface. ال other surfaces هم السوبيريور والانفرولاترال سيرفيس. الانفرولاترال سيرفيسز اثنين كل واحد بجنبه في صورة ثانية. These are the infrolateral surfaces of the bladder. الفوق دي السوبيريور سيرفيس، الورا البوستيريور سيرفيس، القدام ورا البيبك بون اسمه الابيكس، والحتة تحت القبر البروستاتيك يوريثرا اسمها النك. البلادر عندها 6 parts: apex ورا البيبك بون، والنك مع البروستاتيك يوريثرا، وبوستيريور سيرفيس. البوستيريور سيرفيس بتاع البلادر بنسميه البيس، نفس الاسم. السيرفيسز الثانية عندنا superior surface و 2 infralateral surfaces. I want somebody to tell me about the 6 parts of the bladder. You have to do some interaction in this lecture. Tijani. Apex, base, neck, superior surface, and 2 infralateral surfaces. These are the 6 parts of the bladder. The apex is the part behind the pubic bone. The neck is the part before the urethra. The posterior part of the bladder is called the base, the posterior surface, the superior surface, and 2 infralateral surfaces. Is that clear? I want somebody to say yes, or I want somebody to say no, or say them.
Clear, doctor.
Okay.
Yeah.
نمشي نتكلم عن different parts. البوستيريور بارت البلادر when it's empty بتكون الميوكس ممبرين بتاعها بيكون كيرف كده، بيبقى distended when it's full. The only part which is distended even when it's empty is the posterior. دي البلادر is cut from the front، يعني احنا شايفين البلادر من قدام كده. ده اليوريثرا وديل التو ureteric orifices. التراينجل اللي بين اليوريثرا والتو يوريتريك اوريفيسز ده اسمه الترايجون، وده فيه الميوكس ممبرين بيكون stuck to the muscle، عشان كده بيكون السيرفس بتاعه flat even when the bladder is empty. When the bladder is empty الميوكوزا بتاعتها بتبقى شكلها كده curved. It becomes distended when the bladder fills up except for the triangle. For the trigon. The trigon is always flat لأنه الميوكس membrane بتاعه is stuck with the muscle. والtrigon is formed by the 3 angles of the 2 ureteric orifices and the urethra. الridge of muscle بين ال 2 orifices دي اسمها الانتر-ureteric crest. السموث muscle القاعدة around the urethra is called uvula vasicae. behind الuvula vasicae في الحتة دي بتلقى في الميل الميديان bulging opposite to the median lobe of the prostate. انا هوريكم الحاجات دي كلها هنا، بيسموه اليوفيولا بروستاتي. شوفوا البروستات قاعده كيف، دي البلادر بقدام هنا البيبس، دي البروستات. الميديان سيرفيس بتاع الميديان لوب بتاع البروستات ده لما انت عينيه جوا بتلقاه قاعد هنا عامل بولجنج. البولجنج ده اسمه يوفيولا. انا بوريكم في اسماء بس كويس. الترايجون والانتريوريتيريك ريدج واليوفيولا فازايكي والدتروزر muscle والسفنتر فازايكي. These are 6 structures you need to know اللي هم including النك والترايجون. النك قلنا this part of the bladder is called the neck, البارت just before the urethra. انتهينا. الترايجون قلنا هو التراينجل بين التو يوريتيريك orifices مع اليوريثرا، والسيرفس بتاعه بيكون flat even if the bladder is empty لأنه الميوكس membrane بتاعه is stuck to the muscle wall behind. الانتريوريتريك ريتش قلنا هي المسل فولد القاعدة بين التو يوريتريك orifices اللي هي بتعمل الأبر بوردر of the triangle of the trigon. يعني الأبر بوردر of the trigon between the two ureteric orifices دي بيسموه اللي هي muscle fold بيسموها interureteric crest or interureteric ridge. شرحنا النك وشرحنا الترايجون وشرحنا الانتريوتريك ريتش. نجي لليوفيلا بازايكي. في فرق بين الاسفنتر بازايكي واليوفيلا بازايكي. اليوفيلا بازايكي جوا البلادر والاسفنتر بازايكي at the neck of the bladder. لما نرجع للرسمة هنا بتلقى اليوفيلا بازايكي في الحتة دي اللي هي circular muscle around just above the orifice of the urethral orifice. الاسفنتر بازايكي تحتها هنا. بعد ذاك قلنا في حاجة اسمها في حاجة اسمها الديتروزر ماسل هي السموث ماسل. السموث كوت اوف ماسل بتاع البلادر كله اسمه يعني السموث ماسل اوف ذا بلادر اسمها الديتروزر ماسل. اليوفيلا بازايكي قلنا الاسفنتر بازايكي هنا. اليوفيلا بازايكي تلقاها هنا اللي هي عبارة عن شنو؟ الريتش which is formed by the bulge of the median lobe of the prostate into the posterior surface or the base of the bladder back to the orifice of the urethra uvular vasaki. الاسفنتر بازاكي هي thickening of muscle circular component at the neck. طيب أنا هساعد واحد فيكم عايز يوريني السكس structures اللي بتكون البلادر. قلنا الابيكس والبيس والنك وسوبيريور سيرفيس وتو انفرولاترال سيرفيسز. بعد ذاك السكس ستراكشرز اللي قدامنا ديل عندنا النك اوف ذا بلادر، الترايجون، والانتر يوريتريك ريتش اور كريست، واليوفيولا فازايكي، والديتروزر ماسل، والسفنتر فازايكي. any volunteer؟ ليلى أو الصديق. I will help you. I want you to cover this slide. Speak to me about these six structures. What is the neck of the bladder? What is the trigon? What is the interior ridge or crest? What is the uveolar vasaki? What is the detrusor muscle? What is the sphincter vasaki? Layla or Siddiq? Okay, anybody? The neck of the bladder is the lower part of the bladder just before the urethra. اللي هو في الميل الneck of the bladder is formed by the puboprostatic. في الفيميل by the pubovasical ligaments.
The detrusor muscle is the smooth muscular coat of urinary bladder wall with three layers. Where the sphincter vesicae is thickening of the muscular circular component. أيوة.
Excellent. What is the sphincter vesicae?
It's the thickening of the muscle, circular compartment حق في النك.
Excellent. What is the interureteric ridge or crest? Muscle fold between the two ureteric orifices forming the upper border of the trigon.
أيوة.
What is the uvula vesicae? في الترايجون في اللور بارت اوف ذا ترايجون في الابر بارت تلقى الانتريوريتريك كريست هنا. في اللور بارت اوف ذا ترايجون في الميل
it's a small elevation بيكون immediately behind the urethral orifice. Well, that it's produced by an underlying median lobe of the prostate.
of the prostate. So we only find the uvular vasectomy in males.
Males. أيوة.
Excellent. Now we move to the blood supply. The blood supply of the bladder is by the superior and inferior vesical arteries والاثنين من الانترنال iliac artery. احنا قلنا كل الارتيريال سبلاي بتاع الاورجنز في البلفس من الانترنال iliac artery ما عدا 3 arteries اتكلمنا عنها في البلفيك وولز. الفينس بتعمل حاجه بيسموها الفيزايكال فينس بلكسس ودي بتمشي للانترنال iliac vein. Very simple. الليمفاتيك درينج internal واكسترنال iliac lymph nodes. Very simple. النيرف سبلاي انفيريور هايبوجاستريك بلكسس. الانفيريور هايبوجاستريك بلكسس دي قلنا في السيجمويد كولون وفي الريكتم وفي اليوريتر وفي اليورينري بلادر بتدينا سمباثيك وباراسمباثيك فايبرز. بالنسبه للبلادر بتجي من L1 و L2.
دكتور عمار.
Yes.
معلش صوتك قطع علي، ممكن تعيد the last part you just said?
I said the blood supply of the bladder is easy because we said for all pelvic organs the blood supply comes from the internal iliac artery. قلنا في 3 arteries بتدخل البلفس لكن they are not coming from the internal iliac artery. واحد منهم السوبيريور rectal artery اللي قلنا قبل شويه ده اللي هو direct continuation of an inferior mesenteric. الانفيريور mesenteric ده is the last branch of the abdominal aorta. يبقى السوبيريور والانفيريور vesical arteries are branches of the internal iliac artery. Veins are corresponding. There is superior and inferior vesical veins. They both form what we call vesical venous plexus. They go to the internal iliac vein. A lymphatic drainage is simple. It follows the internal and external iliac lymph nodes. والنيرف سبلاي is autonomic nerve supply من الانفيريور hypogastric plexus اللي هي فيها sympathetic postganglionic fibers من L1 و L2. البلادر بتاخد من ال 2 first lumbar segments of the spinal cord من ال 2 first lumbar segments من ال sympathetic trunk postganglionic fibers. أنا هتكلم عن الانفيريور hypogastric plexus والsympathetic والparasympathetic nerve supply في الfunction of the bladder. What is the function of the bladder?
It's stored
Micturition. What's micturition? Urination. Passing urine, storing urine and passing urine. So the process of passing urine or urination, the medical term is micturition. Micturition is passing urine. It's a reflex action controlled by higher centers. يعني هو reflex لكن voluntary to some extent. When we pass urine, we want the convenient time and place to do it. However, in kids, it's a simple reflex, so they can pass urine when the bladder is full. Adults, also within limits, they can control it until it's convenient to pass urine. Given في our lecture قلنا البلادر can take up to 500. Of course, if you take like half a liter, if you take 1 liter, you cannot control it. It's too much more than the capacity of the bladder. But under the capacity of the bladder, it's a voluntary response, so you can control passing urine. A reflex is initiated when the urine is around 300. احنا قلنا النورمال capacity is 500. لما نقصل احنا we will talk يا اخواننا في اليورولوجي في الفيزيولوجي هنتكلم عن الميكتوريشن in detail، لكن في الاناتومي we will just touch on it، يعني هنديكم فكره عنه. لكن لما نتكلم في الرينال سيستم عن الميكتوريشن هنتكلم عن الباث ويز زي ما بروف طارق يتكلم معاكم الدرفات عن التراكس في السباينال كورد والهاير فانكشنز، واحد منهم الميكتوريشن. وفي الفيزيولوجي we will talk in much more detail when we cover the renal physiology about micturition, but now I'm just giving you an idea. So when you start 300 ml of urine, you start what we call the urge. يعني you will feel that you will need to pass urine soon but you still have time. في حاجة اسمها stress receptors دي قاعدة في الجبال. احنا قلنا الريكتم is only the only sensation في الريكتم هو sensation for distension. السensation for distension ده is detected في البلادر as well بحاجة يسموها stretch receptors قاعدة في اليورينري bladder wall. الستريتش receptors دي are stimulated by filling of the bladder. يعني when the bladder fills especially above 300 up to 500 بيحصل stimulation للستريتش receptors في البلادر وول. الستريتش receptors بترسل impulses to the central nervous system. لما تمشي الامبulses للسنترال نيرفس سيستم بيقوم السنترال نيرفس سيستم يقول لك you will need to go to the loo to pass urine soon. So ال H هو higher function بتيجي من البرين لأنه في stretch receptors قاعدة في الوول بتاعت البلادر بتودي عن طريق السباينال كورد impulses للhigher centers في السنترال نيرفس سيستم عشان توريك إنه you will need to pass urine. الباسويز دي فيها afferent و efferent sympathetic و parasympathetic nerves بتمشي through pelvic splanchnic nerves. الباراسمباثيك nerves بيسموها شنو هي الروتس بتاعتها هي S2 و 3 و 4. بيسألوكم من الافرنت فايبرز تمثل S2 و 3 و 4. والافرنت فايبرز بتجي في الهايبوغاستريك بلكسس وبتدخل من الهايبوغاستريك بلكسس ل L1 و L2. So afferent S2 3 4 efferent L1 و L2. الافferent parasympathetic leaves the cord وبتمشي في السبلانكنت نيرس inferior hypogastric plexus وبتدخل اليورينري بلادر وبعد ذاك بتدي سبلاي لحاجتين للديتروزر ماسل اللي هي السموث ماسل اللي في الوول وللسفنتر. الديتروزر ماسل في الديتروزر ماسل before doing the micturition will contract. خلاص انت you are ready to pass water. The detrusor muscle will contract. The sphincter muscle will do the reverse. This is parasympathetic stimulation. There is also a question about micturition. A contraction of the detrusor muscle and relaxation of the sphincter will lead to emptying of the urinary bladder. But this is also helped by increasing the intra-abdominal pressure. Well, intra-abdominal pressure is increased by contraction of the abdominal wall muscles. لما يعني it's not a contraction بتاع الدتروزر براها is sometimes not enough to empty the bladder. بتقوم الابدومين كمان تعمل contraction من برا by increasing the intra-abdominal pressure. والintra-abdominal pressure بيزيد كيف؟ by contraction. لما يحصل contraction للabdominal wall muscles بتزيد البريشر في الابدومين والبريشر في الابدومين بيضغط على البلادر من برا. ده بلس الكونتراكشن بتاع الدتروزر ماسل ذاته بلس الريلاكسيشن بتاع السفنتر will lead to emptying of the bladder. This process is called micturition. It's a complex process, as I said. It involves pathways, sympathetic or parasympathetic, going through the spinal cord to the higher centers. في البونس زي ما هنيجي نتكلم السيريبرال كورتكس. It involves stimulating or the detrusor muscle to contract or stimulating the sphincter to relax through parasympathetic. It's a reflex action, however, it's also controlled in the adults. In the children, young children, it's still a simple reflex. The young children, when they're bladder young, I mean less than 2 years or 3 years, they can wet themselves because once the bladder is full, they will just empty it, or at night. An adult will develop that ability of retaining the urine within limits up to, we said at 500 the bladder is full. Some people they can keep up a little bit more than 500, but it is inhibited by the cerebral cortex, because cerebral cortex will tell you you cannot pass urine now, you need to find the convenient time and place to do it, and then you will wait or find the convenient time and place to do it. الانهبيتوري فايبرز كنا قاعدة في S2 3 and 4. وبعد ده قلنا من 2 to 3 years بيحصل voluntary control، يعني التشايلد بيبدأ يحصل له توالي training. they can keep urine by relaxing the trouser and contracting the sphincter. والعكس بيحصل when they want to pass urine اللي هو contracting the sphincter و relaxing the contracting the trouser and relaxing the sphincter. قلنا the pressure of the trouser muscle might not be enough to empty the bladder. It can be helped by the pressure from the intra-abdominal, we call it intra-abdominal pressure, which is increased by the contraction of the abdominal muscle fibers. We covered the GI and the urinary tract, which are the two systems. We have only one system, which is the genital organs, the reproductive system in the males and females. My last slide is the differences. As I said, when I covered the urinary system here, I covered the urinary system in general, يعني ureter and urinary bladder in males and females. نجي للدifferences. We said because of the presence of the reproductive systems, يعني they are different between males and females, there are slight differences in the urinary system as well. لأن the urinary system is very close to the reproductive system. في الفيميل urinary system اليوريتر بيدخل البلفس زي الميلز في نفس الحتة في البلفيك بريم اللي هي البلفيك انلت وبيدخل قدام الساكرو ايلت جوينت والديفيجن بتاع الانترنال الكومن ايلت انتو انفيريور نفس الحكايه بيمشي باكورد وداونورد زي ما قلنا في الميل للاسكيال سباين اب تو هير زي ذا سيم. بعد ذاك بيمشي فورورد وميديالي زي الميل. الفرق الوحيد انه هنا بيمشي beneath the broad ligament crossed by the uterine artery. في الميل لو ذكرت كبير كان هنا بيكون crossed by the vas deferens. وبعدين بيمشي lateral للفاجينا عشان يدخل البلادر وول، lateral للupper part of the vagina ده في الميل ما في، عشان يدخل behind احنا هسه ما شايفينه عشان يدخل الوول اوف ذا بلادر. يبقى الفرق الوحيد في اليوريتر بين الميل والفيميل هو في اللاست بارت اوف ذا يوريتر. اللاست بارت اوف ذا يوريتر لانه بيجي يوتراين ارتري وبيجي الفاجينا upper part وبيجي اليوترس. في الميل هناك بيكون بس كروس بالباس ديفرنس، فالاناتومي بيكون ديفرنت هنا في الريليشنز. البلادر بالنسبه للشيب والستركشر والبلود سبلاي والليمفاتيك درينج والنيرف سبلاي والميكتيوريشن، كل الحاجات اللي قلناها دي are identical في الفيميلز. What is not similar to males في الفيميلز اللي هي الريليشنز. نمرة واحد there is no prostate في الفيميل. يبقى البلادر بيكون وضعها في الفيميل لتحت شويه، لانه هنا البروستات في الميل بتكون رفعها شويه. لو عينتوا معايا للرسمه دي هنا البلادر في الميل اعلى من الفيميل شويه لانه مرفوعه بالبروستات. في الفيميل هنا ما فيش بروستات. يبقى البلادر اناتوميكالي البوزيشن بتاعها is lower لانها is not raised by the prostatic gland. نمره واحد. يبقى النيك بتاعت البلادر rest directly on the urogenital diaphragm. ما فيش بروستات. الابيكس behind the pubis like the male ما في فرق. البيس separates the vagina from the rectum. The base of the bladder البيس هي البوستيريور سيرفيس اللي فيها الترايجون. كويس. في الميل ما فيش فاجينا هنا. يبقى هنا في الميل بيكون في الريكتم. لما نشوف الرسمه الصوره الثانيه هنا البيز اوف ذا بلادر هنا مع الريكتم طول. هنا there is the vagina, upper part of the vagina between the rectum and the base of the bladder. This is the second difference. قلنا الفيرست difference ان البروستات بتخلي البلادر هاير شويه في الميلز. في الفيميلز البلادر بتنزل لتحت لانه ما في بروستات، بيقوم الحته اللي بتبقى فيها فوق دي بيجي فيها اليوترس. يعني في الميلز تحت البلادر في البروستات، وفي الفيميلز فوق البلادر بتنزل لتحت شويه لانه ما فيش بروستات، لكن فوق ليها بيكون في اليوترس. ورا اليوترس بتلقى الريكتو يوتراين باوتش اوف دوغلاس. في الميل بتلقى الريكتو فيزايكال باوتش ما عنده نيم. طيب السبيريور سيرفيس زي ما وريتكم قبل شويه في الرسمه، في الفيميل بيكون فيه الباوس اوف دوغلاس واليوترس في الفيميل. في الميل ما فيش باوس اوف دوغلاس، بنسميه ريكتو فازايكال باوش لانه ما فيش يوترس وما فيش يوترس. عشان كده في الفيميل السبيريور سيرفيس بتاع الفيميل بتلقى فيه الباوش اوف دوغلاس واليوترس، هناك ما فيش باوش اوف دوغلاس وما فيش يوترس، بتلقى الريكتو فازايكال باوش في الميل. الانفيرولاترال surfaces are similar. الابيكس is similar. الديفرنس بتكون في البيس وفي السيرفيس في السوبيريور سيرفيس. otherwise الشيب والستركشر والبلود سبلاي والليمفاتيك درينج والنيرف سبلاي والمكشوريشن are identical between males and females. We will stop our lecture here. We will just give you more time for revision and questions, and then we'll do the quiz together. So it's over to you if you have any questions or any comments, or if you want to ask any questions before we start the quiz. واضح الكلام ده؟ عندنا 5 minutes هنشتغل فيها.
واضح يا دكتور عمار.
هنشتغل في 5 minutes هنشتغل فيها الكويز مع بعض. من اللي اشتغل الكويز؟
انت قلت من اشتغلوا ولا منهم اشتغلوا؟
روان اشتغلت الكويز ولا ما اشتغلتيها؟
لا لا اشتغلته ايوه قبل المحاضرة.
طيب الباقيين اللي ما اشتغل اللي اشتغل الكويز اعمل ريس هاند. انا شايف كل النيمز بتاعتهم. روان بس، ليلى وشهد. طيب نشتغل كلنا مع بعض. اشتغلت الاول اوكي. نحن غيرناه لان الاول كان كل الانسرز ترو، هو تقريبا نفس الاسئله. عملناها multiple choice question لكن هي نفس الاسئله.
انا ما عملت المالتيبل تشويس الجاني في ارقام يعني
ده الاول.
multiple choice لكن ما العادي.
ما في مشكله، هي الاسئله هي
أيوة.
نفس الاسئله. طيب هنشتغلوا مع بعض، احنا باقي لنا 5 minutes هنشتغلوا مع بعض. Can you see it all of you?
Yes, we can see it.
Yes.
طيب عايز somebody to be in charge to ask the questions and ask if somebody answer or you answer yourself. Who's talking? Rawan, you.
Yes, it's
You read
the
the question
dilated
and tell us.
lower part. Oh, sorry. It's rectal ampulla is A, the dilated lower part of rectum, or B, middle part of the rectum. And the answer is A.
Let us check. True. Go on, Rawan. You'll do all of them, yeah, Rawan.
أيوة.
Then you are the only one who's talking.
خلاص اوكي
Carry
يا
on.
دكتور عمر.
Yeah, read the question.
Micturition can be assisted by A, abdominal muscles contraction, or B, sympathetic overstimulation. And the answer is A.
Well done. Carry on.
Okay, number 3, pelvic diaphragm separates A, false from true pelvis, or B, main pelvic cavity from perineum. The answer is A, I think.
Do you agree with her? What separates false from true pelvis, yeah, Rawan?
Wait, no, sorry.
Is it pelvic inlet?
The pelvic inlet or the brim separates false from true pelvis. I think it doesn't allow.
That was wrong.
Yeah, it was the wrong answer. So what? Sorry, we'll just have to do it again. Sorry. The pelvic diaphragm separates the pelvis from the perineum, and the pelvic inlet separates the false from the true pelvis. Is that clear?
Yes, it's clear.
So we just have to do it all again. Sorry. I think they are in
No,
order.
no
No,
problem,
they're not
sorry.
in order. They're not in order. Carry on.
Okay.
Broad ligaments are
Sorry, السكرين بتظهر لي بعد شوية ما بتظهر لي طوالي عشان كده
okay.
it lags a
Broad
bit.
ligaments
Are
are three-layered peritoneal folds in female pelvic cavity or two-layered peritoneal folds.
it's two layered. B.
Two-layered peritoneal folds. So that's true. So have you seen the screen now?
Yes, it's just a bit delayed, but I see it.
An erectile angle is a sling formed by puborectalis or by obturator internus muscle.
By puborectalis.
True. Next question is pelvic diaphragm separates falls from true pelvis, main pelvic cavity from perineum.
Main pelvic cavity from perineum.
Well done, Yarawan. Micturition can be assisted by abdominal muscles. You have answered that. I think
Yes.
it shuffles them every time. Yeah.
Yeah.
Sphincter vasicae is thickening of longitudinal muscle component at the neck or thickening of circular muscle component.
Of the circular muscle
Okay.
component.
Circular muscle component. Well done. Uvula vasicae is produced by underlying median lobe of the prostate or lateral lobes.
The median lobe.
Well done. True pelvis is between pelvic inlet and outlet, pelvic diaphragm, and perineum.
Pelvic inlet and outlet.
Well done. Trigon of the urinary bladder is the fixed mucous membrane area lining the base or is a mobile area at the base of the bladder?
It's the fixed area.
Yeah, we say it's always fixed لأنه it is stuck to the
Yeah.
muscle. Yeah. Pouch of Douglas position is recto-uterine, basico-uterine.
It's recto-uterine.
Yeah. And the last question is rectal ampulla. You have already answered dilated
Yes, it's
lower.
dilated.
So that's the end of the quiz and the end of the presentation. Thank you very much, guys. This lecture is not finished. In the second half, we will cover the reproductive system. So we'll cover the genital organs in males and females. وبكده نكون خلصنا pelvic cavity. والمرة اللي بعدها هيكون one lecture عن البرينيوم. Any questions?
No, خلاص مفهوم يا دكتور.
شكرا جزيلا. Thank you very much.
شكرا يا دكتور.